Hello, good afternoon to everyone. Good morning to those on the West Coast, and welcome to the learning series on using peer navigation to address health disparities of people with serious mental illnesses. This is our third and final in the series. Today we're going to be focusing on the implementation of peer programs, peer navigator programs. This learning series is brought to you by SAMHSA, the Substance Abuse Mental Health Services Administration, through their Brass Tacks project. Brass Tacks is bringing recovery supports to scale, technical assistance center strategy, and I work with Brass Tacks. My name is Cheryl Gagnon. I am a senior associate at the Center for Social Innovation, where we have the contract. We're so lucky to have both Pat Corrigan and Sonya Valentine back with us this week. I will be turning things over to both of them in just a moment. But just first, a couple of housekeeping items. I see that many of you are already chatting it up in the chat box, and that's really good. It's a box that says comments and questions here and for everyone, and that is where you can put greetings or ask your questions. I will, and some others will kind of pull those questions out and give them to Pat and Sonya to address. So please feel free throughout the whole anytime to post your questions. This session is scheduled for 60 minutes. It is being recorded. We will be archiving this installment as well as the whole learning series, so you can access it after this event. And without any further ado, I will turn it over to Sonya Valentine and Pat Corrigan, and they do a great job introducing themselves. I just want to say thank you and welcome again. Go ahead, Pat. Are you leading today?
I am. Thank you, Cheryl. Thank you all for joining us. Sonya and I are currently sitting on the south side of Chicago, where it's still morning for us. Over the last two webinars, we've been talking broadly about the special skills and values of peer supporters as we focus specifically on the health and wellness needs of people with serious mental illness. What I wanted to do for those who hadn't been in the previous calls is to briefly review what the challenges are in terms of health and wellness for people with serious mental illness, and then talk about the Peer Navigator program that we developed using community-based participatory research. Actually, the lion's share of the call today will be done by Sonya on those issues. And then we want to end up with the most recent developments in peer navigators in terms of diet and exercise, and then share with you dissemination and implementation issues. So let's talk about the health and wellness concerns of people with serious mental illness. Research is quite clear. Sadly, people with serious mental illness will get sick and die 10 to 30 years younger than other people. It's conceivable it can affect every major organ system in the body, in addition to obvious things like cardiovascular disease and respiratory disease. People with serious mental illness can suffer falls, leading to orthopedic injury, can be exposed to infectious disease or communicable disease, even suffer the pillages of cancer and gastrointestinal disorders. This is a bleak picture for people with serious mental illness. It's even worse if the person with mental illness is of color. African Americans and Latinos have been two groups that Sonya and I have specifically looked at. And so we wonder why this occurs. There's several reasons, but we've become particularly interested in and concerned about is insufficient resources, that even though the United States has an excellent healthcare system, healthcare for people of color, for people with mental illness, for people in low income is hugely lacking. And on top of that, the healthcare system frequently represents white male priorities, and so what lacks are culturally relevant services. And so we came up with the idea of peer navigators. For many of you who work in this space, it's somewhat similar to community health workers. Here, though, peer is specifically a person in recovery from serious mental illness. And what they do in terms of health and wellness goals is supportive but practical issues of helping people get to their health care appointments or get to the pharmacy or get to the labs they need. Peers also, our focus has been specifically on people of color. So we've done significant research and intervention on African Americans, and so peers in that case are black people in recovery from serious mental illness. And briefly introduce you, we've done a similar project on Latinos and Latinas with serious mental illness. As we said in our first program, everything we do is governed by community-based participatory research. And so Sonya and a colleague of ours, Lindsay Sheehan, and I developed the Inspiring Change program. This is a how-to manual, how to do community-based participatory research to make sure whatever evolves out of an effort represents, in fact, the people from the community with whom we work. By the way, everything we talk about today can be downloaded from our website. Actually, if you look for resources for download, you'll see some of the things we provide. Similarly, I believe at the end here we'll give you the website, which is chicagohealthdisparities.org. So we worked on and developed manuals, worksheets, fidelity instruments for people of color. Sonya, who is a person with lived experience, is going to share with you her wisdom. Again, this is going to be sort of a mini quickie course of what Sonya talked about last time. Sonya?
Okay, thank you so much. Again, my name is Sonya Valentine, and you can see me on this picture. We love this picture, by the way. Right here, right next to Pat. This was my first experience with CBPR, and the idea was to develop a how-to manual for peer navigators. Since then, I've transitioned into part-time work initially, and now full-time here at Chicago Health Disparities Center. A large part of the work that I do is in the training of peer navigators. I've been on the receiving end of this type of work, and it is now my calling, my passion, my desire to help anyone who wants to help others to develop some type of I'd say relationship, and that's my biggest word, some type of relationship, companionship, friendship that can help an individual transition into the place that they want to be in their life. So again, we're going to do a quick overview of the peer navigation that we have developed here, and a large part of it is the overview of the problem. So your first connection and engagement with that individual is to find out what they want, what their needs are, how can you best serve them. And then throughout our training, we teach people various tools that can help with that engagement and that development of the relationship. And then also the peer navigator is the person that goes out into the community, so they need to have a wealth of resources. They need to know where to go to very quickly to get needs met, because you have to be quick on your toes in this type of relationship and position. Again, these same things were transitioned from the African American experience that we had in that CBPR team to the Latino and Latina population here in Chicagoland, which is very large. There were certain specific concerns that we wanted to develop for them, things like, of course, language barriers, documentation concerns, and improving their quality of integrated care. So let's go very quickly over the overview of what the peer navigator's focus is. What we're doing is we're recovery focused. We're not entering into this relationship focusing on the problems or the issues or the illness. We're here to focus on recovery. We know that people, when they believe they can recover, we can help to transition them into that place. And what recovery looks like for the person is individualized. It's a very unique experience that we would like to guide this person through. We're accepting, which means that we meet the person where they are. Empowering is that they have to know they are running this ship. We want to encourage, we want to support, we want to motivate, and more than anything, we want to inspire and lead by example. Goals are what allows a person to see where they are in the spectrum of things. So we start at one place and we move towards the place that they want to be. And of course, they're working in the community. Now, community can be many different things. It can be your church home. It could be your neighborhood. It can be the place that you go through to shop and to engage with others. It could be the bingo. See, I like bingo. I was moderating a bingo session with some of the participants, and so when they see me, hey, there's the bingo lady. I love that. That's a good thing. Okay? So the fundamental approach is that we're proactive. We're not just sitting back and waiting. We're actually coming to you. We want the individual to know that we care. We want to engage. So we have these conversations that are questions and answers. Throughout that process, I'm allowed to share certain parts of my story and my lived experience, which allows the individual to be able to share parts of their story. Again, there's no one set topic that we work on. I'm there to help them with anything that's going on in general with their lives. So it's hard for me to help an individual focus on healthy eating and activity when they're homeless. So that may be one of the things that we can tackle first. So there's a broad focus. Being an active listener is a skill and a talent within itself, but we know that peer navigators, when given these tools, can refine them and really learn how to listen intently to what the individual is trying to communicate to them. So we're happy about that. Shared decision-making is something that we know that the healthcare environment is moving towards. So we want the individual to have the information and the knowledge that they need to make an informed decision, and we're there to just support them and help them and give them options that they may not be aware of. And the other part is problem solving, okay? So if I know that a person has a certain amount of link or food stamps at a certain time of the month, and they like certain foods, but they don't have enough money to take them throughout the entire month, then this is a problem. This is something that can be solved. There are options out there, and this is what the peer navigator focuses on. Minimizing these barriers and obstacles and maximizing the quality of care that the individual receives. So let's go a little bit into the helping skills. Again, we talked about this last week, and this is comprised of working with the person, responding to their concerns, and managing my role. Now, a major difference between responding to their concerns and managing my role is that because I'm a peer and because I have been out of the work world for several years, I understand that in managing my role, I'm going to also be interacting with other professionals. And so I need to maintain this level of professionalism while also being able to respond to the concerns of my participants using my lived experience skills. So there's a fine line that I walk, but when trained well, it can be done, and it's actually a very great experience. So in the trainings that I've done with peer navigators, we teach reflective listening. We teach engaging through goal setting. We teach motivational interviewing, strengths modeling, taking the person where they are and helping them to become aware of the strengths that they already have. We advocate, and we also do a lot with managing symptoms and relapse management. So the interpersonal problem-solving skills are something that we want to address relatively early in this relationship, because I know that when I was going through my life experiences, one of the things that I was faced with was a lot of decisions and that feeling of being overwhelmed. There was this feeling of desperation at times and hopelessness. So I want to connect with this individual to let them know that there are solutions to these problems. So we don't focus so much on the problem as we do the solution. We talk about the problem in order to get to a solution. Now with that comes the skills of management. And this is more of a relationship management. So I have to manage the aggression. Maybe I can help to de-escalate a problem or an episode, and as far as relapse is concerned, we can see the early signs because we understand that relapse is a process. It's not an event. It just doesn't happen overnight. It's something that is worked out over the course of time. So with that in mind, once I get to know this individual, I'm able to see and maybe help them to become aware of things they may be doing or not doing that will help them to stay healthy and productive, because that's really what they want in most cases. I use harm reduction, meaning that I'm not there to tell you what to do. I'm not there to make you do anything. All I want to do is lessen the negative effects on you, your family, and your close friends. I use cultural competence in order to connect with that individual. And a large part of the people that I work with are African Americans with serious mental illness like myself. So there are times that I'm able to move in and out of terminologies and just help the person to feel welcomed and accepted and belonging. That's a large part of this. It's not about judging the individual. It's about meeting them where they are. Of course, we know that mental health and physical health crisis management is of utmost concern, because when I'm not feeling well, or when I'm feeling overwhelmed, or when I'm physically in pain, it's hard to get those goals met. And then, of course, I want to be trauma-informed, because the last thing I want to do is re-traumatize people. I've had various amounts of trauma in my life, and there's a learned training that comes along with our peer navigation about being trauma-informed. When we're using these listening skills, because of course we know there are roadblocks to listening, and we may cover that a little bit later, but we know, let me just touch on that, judging, avoiding, those are things that as an adult woman, I do. Sometimes I do them unconsciously. Sometimes I do them consciously, thinking that I can deter a person from doing something that may be harmful to them. But those aren't the skills that we're trying to hone here. We're honing good listening skills, which deals with the attending, meaning your posture, your body language, being in an environment that will allow the person to be forthcoming and trusting and even vulnerable at times. There are times when I need to be just in a quiet place so that I can really have time to think about what I'm going to say and what I'm hearing, so that I'm able to receive, understand, and then continue to listen and move forward. We use reflecting skills, which just means that I'm letting you know that I'm listening to you, because I'm able to summarize it and paraphrase it and get to the root of maybe your emotional concerns as well as the obvious concerns. Along with being homeless comes the lack of safety and security of being able to take a shower when you want, being able to use the restroom when you want. These are all things that can cause an individual to be very frustrated about what they're going through on a day-to-day basis. And so these are the things that I want to hear and connect with them about. I use a lot of motivational interviewing, because more than anything, I want the person to feel like a change can be made, and that we're in that process right now of becoming healthy and productive and being a part of mainstream society, if that's what they want. But more than anything, many of the people I work with want to have a healthy relationship with family, friends, and spouses. And so I have to find out what motivates you. What would put you in a place of being willing or ready to change. One of the things that I notice about motivational interviewing for myself, this is the worksheet that we use, we have to look at the pros and cons of making that change. So one thing that I realized is that there were times in my own experience that I was willing, I'm tired of being in this position. I'm willing to do whatever it takes in this moment. Sometimes willingness can be a little fleeting. So I have to use this level of willingness while I have it. And then, but there would be times that I wasn't quite ready. No, I ain't really ready. I got to go over here and get this money, or I got to go do this. I'm not quite ready right now. But what I do know is that once willingness and readiness meet, that's when the miracle happens. And we have seen the miracle happen. I have experienced it in my own life, and I've seen it happen in others. And so that's what we do in this type of motivational interviewing. We find out and we help the individual to find out where they are on the willingness scale and the readiness scale, and that's where we meet them, so that we're able to target specific behaviors that they would like to change. So let's go into advocacy now. Being an advocate gives me, it's part of my passion, because I know that there were times in my life that I knew I felt a certain way, but I wasn't quite able to articulate it. So a large part of our advocacy role is about supporting that person, educating the person, giving them the information that they need to be able to speak articulately to whomever they may be wanting to communicate with. So, and then sometimes I can be the spokesperson. So I can say in my own life with my mother and her health care concerns, I love the patient portal. She does not particularly care for the patient portal. So I use the patient portal to speak with doctors, make appointments, and do things that she wants me to do. So I'm basically just working on her behalf. And even though I may not agree with what she wants, I'm there because I'm her advocate. I'm there to do what she wants me to do. And that's what a peer navigator does. Also, as far as an intermediary is concerned, sometimes I may sit in with her on her appointments and ask questions that I may hear the provider giving the answer to, but my mother may not fully understand. So it's just a matter of helping the individual to understand what is being communicated to them also. So this is a role that I step into only when asked. I like to get in really where I fit in. I really want the person to feel empowered, that they are making the changes. I'm just there for the ride. I'm there to help them with the journey. But it's about them leading us the way we want to go. Now, again, when we talk about relapse management, a lot of my own lived experiences with substance use, untreated mental health concerns. I've been sober now for almost 6 years, we'll say 6 years, and I celebrate my sobriety in July. And I've been housed permanently for the first time in a very long time over the last 6 years also. So a large part of my relapse management is about doing the things that I know work and making little adjustments to things that may no longer work as effectively as they used to work. So that's what I'm there for. And in a lot of ways, I may share my own personal experience with these individuals, whether it be helping them with self-help programs, helping them with healthy eating and activity, being able to know and help manage symptoms and triggering situations that may cause them to feel overwhelmed or fearful. And so these are some of the things that, because of my own experience, I'm able to help peer navigators wherever they are and whatever that triggering episode may be.
Your call has been placed in conference. Line muted.
Should be on the phone. If you go ahead and...
Did you two hear me?
Yes. Loud and clear.
Oh. Well, that was a lot of work I put in that got to be heard.
It has been recorded as well. Okay, it seems like the sound is back on. So, again, we will turn things to Pat Corrigan to pick up where Sonya left off.
Great.
Thank you.
And thank you, Sonya, for your comments. Part of the dialogue that's been going on is where can you get this information? What Sonya just reviewed is literally taken out of the manual, which is about a 100-page manual that our team of African Americans with serious mental illness developed over about a year-long effort. It also includes worksheets with peer navigators who can actually sit down with people managing their health issues and use them. And Brass Tacks, Cheryl, will give you how to download that. If you look in the lower left-hand corner, this work is supported by the National Institute of Minority Health and Health Disparities, and so all of this work is in the public domain for you to use as you like. What we want to end today with is some discussion of how you might partner with us if you're so interested in terms of dissemination and implementation. But first, I want to share with you our most recent adaptation. Part of the health and wellness concerns of people with serious mental illness are tied to diet and exercise. In fact, that applies to all people. One way to promote wellness and deal with the health concerns that most Americans are struggling with is to look at our patterns of activity and the kind of food we eat. Over the last 5 to 10 years, advocates have partnered with clinicians to develop diet and exercise recommendations, specifically adjusted to help people with serious mental illness with symptoms, cognitive disabilities, interpersonal challenges, so they can learn from the program. We, about 2 years ago, proposed to the National Institute of Minority Health and Health Disparities a concern. If diet is fundamentally a way towards health, and you live in a food desert, Chicago, like many major urban areas, have parts of the city where there are no typical large food stores that provide healthy food. Or even more, if you live in an activity desert, activity deserts occur because you live in areas that are not safe, and so how can you go out and do exercise if you're concerned about your personal health? We were wondering how peer navigators might help people with their diet and exercise needs. And so in particular, we're in the middle of a study, and we developed a manual, Behavior for Healthy Lifestyles, where in part we're teaching, again, this program is specifically focused on African Americans with serious mental illness. In part, we're teaching African Americans with serious mental illness how to manage your diet and exercise, and that includes peer navigators who go into their communities and help them meet the practical goals of finding healthy food and exercising in safe places. So what we've done over the last several weeks is looked at the problem, proposed peer navigators as one solution, talked about how community-based participatory research is a way to do that. Community-based participatory research is fundamentally research, and so we do also have some data that shows that these programs, the program for homeless people with mental illness, has a positive impact, and it's also published in the literature. And if you get hold of us, if you go to our website, you can download these journal articles fully. Not to put you to sleep because it's 12:30, but briefly to review what the research shows. This is the impact of peer navigators on African Americans who are homeless with serious mental illness. And what we're trying to measure is the degree to which participants had scheduled appointments. The dashed line at the top are people who got peer navigator services. The pointed line at the bottom are people who did not. And what you can see is during engagement, there's no real change between the two groups because, after all, the people receiving services are just sort of getting used to the peer navigators. But after 3 months of engagement, there's a noticeable impact, a noticeable increase to the degree to which people receiving services were getting scheduled appointments, an impact that maintained for the last 3 months of the study. We then were interested in what is the impact of peer navigators on physical health and And so in this case, to keep you on your toes, we changed the lines. The solid line are people who received the peer navigator. The checked line are people in the control group. And we're interested in the degree to which participants reported their health, their physical illness as less a problem. And you again can see the people receiving peer navigators over the course of the 12 months of the study reported significant less impact of health upon them. This also looked at the perceived physical and mental health, the degree to which research participants thought they just felt better, both physically and mentally. Again, the solid black line are research participants in the peer navigator group. The checked line are people in the control group. And it's quite apparent over the 12 months of the study, there's a significant increase in those receiving peer navigator services. Also, we're very recovery focused, and so we use the recovery assessment scale as a way to assess the impact of peer navigators. Again, that's the solid line versus the impact on control group, which is the dashed line. And you see over the last 3-month period of the grant, people in the peer navigator group reported significantly better personal recovery. They also reported significantly better quality of life. So our findings suggested for the African American study that participants in it got more services, felt healthily better, reported better sense of recovery, and a better quality of life. We have a separate study on the Latino project, which pretty much showed the same results. So that leaves us with the issue of dissemination. One of the challenges is sustaining a good intervention once the federal government supports it and tests it. And Sonya and I and another colleague, John Larson, have developed a training arm. And the goal is to try to teach peers to do peer navigator services. Again, we focus on the object, for lack of a better word. The people we want to train are people with lived experience, are people in recovery, are people from the ethnic community. Do they need to have school or professional requirements? I mean, I don't really think going to graduate school, even undergraduate school for years and years and years makes you a better peer navigator, so we would argue no. But we think for this to be successful, the peer navigators can't be left hanging out there on their own. If an agency is going to do this, then the executive director of the agency needs to explicitly commit to the program, which means, among other things, learn about the program which we've gone through and supervise peer navigators where they clearly let the peer navigator know part of your job, what we're here to do, is help you get out there and provide this very valuable service. The training program typically involves Sonya and one of the other master trainers coming to the agency and essentially walking through the content of the manual, the workbook. You may have seen this issue of fidelity. Fidelity in research is the idea of whether the program is being done the way the program developers meant it to be. So it's just a checklist where a third person can watch the peer navigator to make sure they're doing it the appropriate way. We similarly have outcome assessment measures, user-friendly measures, so that people can evaluate it if they want to. And as I said, what's essential to everything we do is training our people with lived experience. So we're in the midst of this large study of peer navigators for diet and exercise, and Sonya is the trainer. We're also very invested in master training, so if Sonya comes out and spends 2 days with you and does the training, on top of that we want to train a master trainer so he or she can keep it going once we leave. Sometimes dissemination is easy. It's implementation that can be the hard thing. Dissemination is the training, implementation is keeping it going. So typically we include a 1-year tech support program. Again, Sonya and one of our other trainers would join you in some sort of platform where we would review key aspects of it, but more importantly get feedback from the peer navigators on what's working and what's not. Again, this is sort of an interactive process, so while Sonya has great wisdom, people in the field would have good insight for where they're at too. But again, I cannot understate or overstate the importance of making sure administration and supervisors are involved in this. We've worked with large healthcare systems, and sometimes peer navigators who are unbelievably skilled are not given the platform to do the work they do. And so part of the implementation plan is to make sure the agency is fully integrated peer navigators into provider teams as peers. So we definitely don't want any kind of hierarchical system where peers are sort of at the bottom of the hierarchy. I mean, in my opinion, that's so amazingly ironic, since I really think much of what goes on in the community, peers are the strong, independent source. The other very practical aspect of this is how to get it, how to pay for it to get it going. You know, in some ways, we have 50 independent payer systems in the United States, which each state deciding how it wants to pay for mental health services. I know, for example, that the state of Illinois and its Medicaid reimbursement is struggling with how that exactly translates into services provided by peers. And finally, it's important to provide ongoing quality assurance. So again, we want to provide a situation where participants can decide for themselves whether the program is being done the way it's supposed to. That's fidelity assessment. Fidelity assessment is partly tracking, but more importantly, providing opportunities for supervisors to sit down with peer navigators to get some sense of how it's going, what needs to be adapted. And then even more, impact assessment is how to determine whether it's in fact having a real impact. Sonya and I wanted to start a little early today to make sure we had time for questions or comments from the group. To end, these are our email addresses. You'll find Sonya and I do this work as a lifestyle. It's very important to us, so we'll respond quickly. Also, Sonya and I work out of the Chicago Health Disparities Center. That's our website. Again, all these manuals and the like can be downloaded from there. Cheryl, we'll turn it back to you.
Oh, thank you so much, Pat and Sonya. That was wonderful. I apologize to those who lost audio for a brief moment. Understand that this is being recorded, and you can access the link. That we'll send the links to you, and you can hear the portion perhaps that you missed. So I'm going to start with some easy ones. Who can I contact to get more information on the Navigator Master Training Program? So you have a master trainer. Would that be contacting you, or?
Either one of us. The master trainee is embedded in the face-to-face training when we come out. Sonya and one of her partners will come out and do it. Again, the idea of the master training in the 2-day training is not just how to do peer navigators, but how to teach other people to do it.
Right. And speaking of teaching other people, there was a question about what your training looks like. Do you use evidence-based programming, or was this curriculum you developed? What does the training event look like when you're training peer navigators?
So let me start, and then Sonya can jump in.
Okay.
So we're a manualized program. The program, again, the skills that Sonya just went through are spelled out in great detail in the manual. The trick, as many people on the phone realize, is what's in the manual can be frequently easier than what's in reality. So Sonya teaches this with role plays, getting from you challenges in your community. Also, the training isn't limited to the 2 days. Actually, when you come up with good ideas and then we go away, It's the ongoing tech support, which is a great opportunity to talk about how does this translate or how does that translate. Finally, let me say that while I think peer support providers have unbelievable value on all levels, this particular program is specifically focused on health and wellness. And so the training is how to help people with serious mental illness accomplish their health and wellness goals.
Mm-hmm. And also in the trainings that I have done, it is, yes, so the science is there. We know that motivational interviewing works. We also know that good listening skills work. So these are things that are there, and we have the footnotes at the bottom throughout all of the manuals. So some parts of it were taken from the University of Chicago and other resources that we've used, but of course we modified it in a way to address the specific concerns of African Americans with serious mental illness and Latino and Latinas. But I also want to say this. I'm vested in this type of work. People have helped me on my journey, and I realize that a large part of my own personal health and wellness and level of productivity comes from helping others. So during that process, I'm able to reflect on where I am or where I want to be, and I'm able to share these things with the people that I'm training. So I'm at a place in my own recovery where I feel very comfortable talking about some of the intricate details of my life, and I'm able to befriend, I'm willing to befriend the individuals that I train. And so in these sessions, we've become very close. So that's the part of it that I know works. It's about being willing to connect with someone else on a very personal, vulnerable level. So I can say that.
Thank you. And just a quick follow-up, there was a question about the cost of the training. Have you priced out what it costs to train, I would imagine both the 2-day training and the ongoing technical support?
So, of course, talking to you individually, you'd be glad to do it. Mostly the cost is to get us there and pay for our time to do it. Ballpark at this point for a 2-day training and ongoing tech support is about $12,000 to $15,000. Again, it depends where you are in the country. Unfortunately for our Hawaiian colleagues, getting to Hawaii is a bit more expensive than getting to Indiana.
Yeah. Okay.
I see also, I'm reading along with you, our training scholarships available. So training at this point for us has been focused on agency-based because at this point we believe peer navigators need to be embedded within a healthcare system. I think Sonya and I would be interested in doing a mini course on this at a program like the International Peer Support Association, International INAPS. Of course, doing 2 days at INAPS would overwhelm the schedule, but at this point, right.
Okay, thank you. There were some specific questions about the funding for your research project. Who conducted that research, Pat and Sonya, and who was it a grant? Who fit the bill for that?
So we've currently had 6 federally funded projects. 2 of them are by the National Institute of Minority Health and Health Disparities, which is an arm of the National Institute of Health, and the remainder of them are in the Patient-Centered Outcomes Research Institute, PCORI, which is an arm of the Affordable Care Act, Obamacare. I also see part of the question here is how do the peer navigators get paid? In these research studies, at least half the budget went to the peer navigators to do the strategy. Sonya, who does the supervision of the peer navigators, gets paid through my home university.
Okay, thank you. Thank you. Is there a time frame? This is specific to the peer navigator role. Is there a time frame when peer navigation ends? How is that decided, sort of the period of time in which a person would work with a peer navigator?
You know, the peer support specialists on the phone know this is a recurring concern. In supported employment, should peer services be limited? In supported education, should they be limited? In supporting housing, generally, no. They should be ongoing. In fact, in some ways, it's such a sad irony to provide all these supports and pull it. The challenge is just to find the funding to provide it in an ongoing format. Again, our statement earlier about part of the training is to work with the administration to determine how, for example, local Medicaid funding would pay for this is key to what we would do. So if it can go ongoing, yay. If, on the other hand, it can't, which, again, unfortunately is a lot of peer support services, then I think we need to decide how to pull away from the person's life somewhat efficiently. I think one solution to that is there's a lot of wonderful peer support groups, the Depression and Bipolar Support Alliance, for example, and a degree to which you could educate a person to sort of segue to them might be a good approach.
Mm-hmm. Yes.
So Sonya, kind of in your work, what are some kind of natural ways that the peer navigator relationship, you know, either ended or transitioned to something else?
For me, the whole idea is to educate, inform, and support this individual to feel their own sense of empowerment and strength. One of the major things is that I may even say to some of the people that I work with, you know, you have the answers. I'm just here to help pull them out of you. So whether I'm in your life or not, you are the answer. And so that's a big part of it, to develop a relationship with an individual that's not dependent or codependent. It's very independent natured. So a lot of the people I still see, we still talk. It's not so much about the payment because it's not a part of my day-to-day activities anymore, but we've developed a relationship, and that's something that you just don't cut off. They know that I've transitioned into other areas and something else. But they also know that I'm here to talk with them and to support them and to still give them information that I have because I am more than anything their peer. So that's the best part of it. It's the relationships that continue going on regardless of the monetary value or the day-to-day responsibilities.
Thank you, Sonya. So here's a naughty question many of us deal with. So when navigating the system with a client, how do you address issues around cultural competency or the lack of cultural competency among many providers? Again, whether that's a PCP, personal care physician, or a therapist or other services that might not really reflect the needs of certain cultures. How do you address that in your work?
So
Sonya,
okay, you want to go ahead, Pat?
No, I was going to say you start.
Well, one of the things that I understand is I have to be informed about what I need and also what I want. And with that in mind, if a person is not culturally sensitive or competent to what I face in my day-to-day life, it's my duty to politely and diplomatically educate them to a certain extent, particularly if I feel comfortable with this specific provider, or I have a therapist, and there are just certain things that I tell her about my culture because I trust her. I've developed a relationship with her. And even though I may get upset or a little annoyed by some of those things, I have a vested interest in letting her know this and being honest and telling her where we kind of strayed off. So it's my duty, but I'm not confrontational and I'm not condescending. I'm doing this because I want to maintain this relationship, and I want this relationship to continue to grow and flourish. So it's an individual choice. This is someone in my life that I want to maintain a relationship with, and if she does not have that information, I want to provide it to her in a very polite and kind way. So I find that when I am faced, oh, wait a minute. Oh, it's still on, but my screen timed out, but when I'm faced with this issue or with this situation, I can take it as a learning experience for both me and that individual. There was a time that it may have triggered me to be upset, but throughout the course of my own journey, I've learned how to address those issues relatively well. Pat, did you have something you wanted to add?
Yeah, so I agree with the questioner. Cultural competence is, as we said at the beginning of this, one of the major barriers to providing services to people. I think one way it's explicit is the peer navigator is a person from the same ethnic background. So, and in reaching out to the care provider, we're somewhat explicit about cultural competence being important. I think a peer navigator like Sonya would be quite willing to provide suggestions to the physician about what are more appropriate ways. That said, I think we all agree on the phone this is a major hurdle, one that we need to continue to pursue.
Thank you. And this is kind of a two-part question. One is a general question about supervision, kind of what is the structure, format, frequency, et cetera, of supervision of peer navigators. And I know, Sonya, you provide a lot of that supervision. And then secondly, part of that is how do you cope with exposure to stresses or other traumatic types of information or experiences that people share with the peer navigators? So how do you support them to perhaps navigate their own kind of historical experiences of trauma, or that what's known as vicarious trauma, what comes up in the work?
So, well, I'll answer the second question first. So that's two-part. Professionally, we have mapped that out in the manual. A lot of it has to do with managing burnout, stress management. So we've given a lot of information and a lot of attention to detail in that area in the manual and the workbook. So keep this in mind. As a trainer, I use the manual, and the people that I'm training use the workbook, and so we're able to do a lot of role-playing, situational concerns and episodes and things like that. So that's that professional part of it. So the personal part of it is that I find it very fulfilling for me to have my own structure of staying balanced and in recovery. So I have a therapist. I have my own support team of people that that I'm able to speak with, not about the specifics of what someone is telling me, because confidentiality is of the utmost importance to me. So I'm not talking about any of those things. However, I discuss a lot of my own triggers and my own self-care methods with my own healthcare team. So that's major for me, to continue to develop my own support system so that they're there and I'm able to speak to the intricacies of my own health. So those are two various ways that it's approached. The first question, would you like to answer that? The supervision, Pat? What the idea of the implementation of supervision?
Yeah, so supervision is obviously essential. Whether you're a peer provider or a licensed psychologist, everybody needs regular supervision, because you're right, it's stressful. It's stressful hearing the challenges of other people. Vicarious trauma is an excellent way to say it. So we train and provide direct feedback to the supervisor on the peer navigator team. And the study we're doing right now on diet and exercise peer navigators is a team of 3 peer navigators. One of them had previous experience as a peer navigator and as a supervisor. One part of the feedback we give them is the fidelity information to share with them from the research standpoint how it looks like they're doing. But even more importantly is just to provide a caring situation where people with lived experience can share their challenges.
So that supervision is really, it can be focused both on kind of the managing the performance of peer navigation skills, but also great attention to the peer navigator themselves so they can kind of grapple with issues that come up.
Yeah, again, I want to echo the wisdom in the question. Being a helper is stressful, and so we go into it knowing there's a structure where there's a place to deal with that stress, not the feeling the peer navigator's out there by her or himself.
Mm-hmm.
So do you offer individual supervision, group supervision, or both?
So we as tech support provide supervision to the team, but in putting the team together, we ask administration and the team to designate a supervisor. So there is a peer navigator, preferably somebody with more experience, who Sonya would provide separate supervision to. Again, you can't quite see today, but over Sonya's shoulder is Novi and Julius, who are 2 peers doing work for our projects now, and Sonya provides supervision to them so they can go provide ongoing supervision.
That's great. So you have a whole chain of peer navigators who are supervisors, and great.
Yeah.
Okay, so I see that we're nearly finished with the learning series. I want to first of all, thank both Pat Corrigan and Sonya Valentine for offering and presenting such a rich series for us. People have really responded how much that they have learned about peer navigation to address health disparities. People have been really excited about it. We've had good attendance and good participation. So I want to thank all the attendees as well. I appreciate your questions and comments in the chat box. That's kind of kept things lively. One reminder that there are resources for download listed here. One will bring you right to the health disparities site, and you can download the manual there. So and also the PowerPoint for this. We will also be sending out links to the audio, to the recording of this, so the audio and visual of it. Right after we say goodbye today, the same thing will happen. On your screen will pop up a satisfaction survey, and we appreciate you taking just a moment to give us your feedback. This was the first learning series that Brass Tacks has produced and put out, so we're very eager to hear how things went for you. Okay, so without, I will say good night, goodbye, good afternoon to all of you. Where are we? Yeah, so afternoon on the East Coast, good morning to the West Coast, folks. Happy Thursday, and we'll see you again.
Thank you.
Bye-bye. Bye.
Bye-bye.